And you're still live here on this Joy News special thought leadership event on the dialysis crisis. And we have the panel helping us navigate this very complex challenge. And you've been listening to Dr. Anthony Nsiasari, who is a presidential advisor on health. He's here with me in the studio. You've heard from Perpetual Furiampofo, who's the president of the Ghana Registered Nurses and Midwives Association. Kwame Sapona-Siedu, you've heard from him as well. He's a pharmacist by profession, a Democracy and Development Fellow in Public Health at the Ghana Center for Democratic Development. Professor Samson Enkwi, the president of the Ghana Kidney Association and professor of child health and pediatric nephrology at the KNUST, gave us some really startling statistics regarding the number of children dying every year at the Confanoche Teaching Hospital, 25 to 40 of them when they come in at that stage when it's too late to help them. We also have Dr. Opokuwari Ampoma, who is the Chief Executive Officer of the Kolebu Teaching Hospital. Oswald Nisia-Mensah will join us right now because he is the Director of Corporate Affairs at the National Health Insurance Authority. We'll hear his thoughts on the subject very, very soon because as you heard, the solution lies with the National Health Insurance scheme taking up the cost of dialysis. Dr. Titus Berry will also join us. He's a former General Secretary of the Ghana Medical Association. And Kojo Yangsing is also in the Joy 99.7 FM studio with his own panel. And Kojo, I came over during the break and I realized that there is a lot of questions that we can anticipate from your panelists to mine here in the Joy News studio.
Absolutely, Evans. I mean, Kojo Bafo Ahinkra has end-stage kidney failure. He's been living with it for 8 years. Without dialysis, he will die. He's in the same boat as Thomas Vincent Khan, who is now no stranger to our networks. We've heard about how he's been a kidney patient for 10 years, more than a decade actually, and lives on 2 sessions of dialysis minimum every week. Otherwise, he'll be resting in peace. These are stories that are real. These are the people behind the statistics. And of course, we have James McKeon Amwa, Senior Nursing Officer, Renal Dialysis Unit of Kolebu Teaching Hospital. He also happens to be the national organizer for the Ghana Public Health Association. He's been giving us the stories from the trenches. Also with us representing the Ghana Health Service is Dr. Fred Adumako Boating. He's the Regional Director of Health Service in the Bono East region. He's taken us on a tour of the wellness centers that his region has been implementing. Back to you, Evans.
Thank you very much, Kojo. And this week, as we focused on the dialysis crisis with our series of features, we also heard from the World Health Organization, the country representative, Dr. Francis Kasolo. Listen to what he had to say about this.
To see and discuss with the colleagues who are in the, for example, Kolebu, to understand the reason for the increase. But like I mentioned, if our health insurance is strong, it can mitigate the cost of even renal care if the renal care is one of the on the benefit package of the health insurance. So it is for us to really support the health insurance and to ensure that services such as renal services are included in the benefit package of the health insurance to mitigate the out-of-pocket expenditures that we are beginning to see increase. And if that works, then we will have solved part of the problem of increasing out-of-pocket expenditure that we see with the dialysis costs. WHO, we work with the government, and we're working, for example, with also the National Health Insurance Scheme.
And thankfully, as I said, we have the National Health Insurance Authority's rep with us. He's Oswald Nisia-Mensah, Director of Corporate Affairs there. Oswald, so when is the National Health Insurance Scheme going to take up the cost of dialysis?
Thank you very much.
Great.
Yeah, thank you very much. Thanks for having me. Let me acknowledge my seniors in the studio with you, Senior Odadie and Senior Pescoba with you there. This conversations is very important, Ivan Samasi, and I've been listening and I've been online for the past almost 2 hours, listening to the plight of the patients and all the contributions that have come from my co-panelists. It's very critical. And for me, I would say that the conversation must not stop. it mustn't stop. And I recognize that a lot of things that have been said on this forum, have snippets of solutions. But in summary, what I'll say is we must have a coordinated and holistic and a sustainable approach to these challenges that's confronting us today. I hear we're talking about a stopgap measure of injecting some capital into Kolebu to get it up and running. But the question is, how sustainable would that be even going forward? Dr. Kasolo is right in saying that let's support the NHIS to do this. NHIA, as we all know, has its own set of constraints. It's a scheme that was funded 20 years ago. This year, we're celebrating 20 years of the scheme. But what is critical is that the funding to the scheme has remained almost the same in terms of our premium collection. One of the co-panelists also mentioned, as we speak today, the informal sector, these are people who are not on slate, pay at most 30 cedis for a whole year on being on the National Health Insurance Scheme. And if you're a slate contributor, you're paying something around 6 or 7 cedis as processing fee for a whole year. About 70% of the members on the scheme do not pay any form of premium. How can this scheme stand on its feet and shoulder all these disease conditions that is being thrown at NHIS on a continuous basis? As we speak, there's call for inclusion of prostate cancer, there's call for mental health, there's call for dialysis. All the calls keep coming, but the conversation stops at how NHIA will fund all of this. So the conversation must continue. The biggest source of revenue for NHIA is the levies, which contributes about, this NHIL levies contributes about almost 93%. The levies come in, and as again, co-panelists have rightly said, doesn't come straight to the NHIA. It goes into a central fund for reasons. Of course, the fund itself is also capped. So even monies that is allocated to the scheme is not received at the end of the year in totality. That gap, of course, we know goes to fund other emergencies and so on and so forth. But we must have that conversation to an extent where what is due NHI perhaps should come to NHIS. So NHI will be liquid enough and to be able to take on everything that is being thrown at it. In the landscape of our health architecture, the providers are providing services. Ordinarily, NHI should be the payer and should be able to pay. But from the onset, the framers of the law knew why certain conditions were excluded from the scheme. It's been 20 years on. So we have to get back to the basics and to see whether it's now time for us to include certain conditions which today are becoming an issue. Lifestyle diseases, as has been said. At the center of all this conversation is finding sustainable funding mechanisms to pay for dialysis, to pay for everything else. This conversation must not stop. And I'll say it should continue for us to have a common ground where the NHIS is liquid, there's inflows, and the inflows is able to take on new disease conditions as we go forward.
Okay, do I hear you say until that is done, you cannot cover the cost of dialysis?
As it stands today, there's conversations, and this has started, of course, based on your documentary. Even at the NHI level, the board is discussing, there's a committee that has been set up to have these conversations about dialysis, its implications, if NHI can do anything about it, and most importantly, make recommendations for the policymakers. And I'm happy Senior says there's a lot happening in that space. The Ministry of Health drives policy in our landscape. So whatever recommendations that the board will come up with will be passed on to the ministry and the policymakers for a direction on where we go. But as it stands today, by law, the renal disease is on our exclusions list, which means that we will not be able to fund that as we speak today.
And then did you say that a committee has now been set up to review and consider whether you can afford to take the dialysis cost? Is that what it is?
Yes. Okay. Before NHIA can take on any disease condition, we must do actual studies to be sure that the scheme is sustainable when we put on board any new disease conditions. We have done some for mental health, we've done for prostate, and as it stands today, even when we add on mental health. It doesn't look too good, so we have to try and make sure that the NHI will be sustainable once we decide as a country to put mental health on, prostate cancer, and now we're talking about dialysis.
Okay.
So we must do studies and be sure that NHI will be sustainable going forward.
And also, you also said two things about making NHIS funding sustainable. One, you talked about the contributions and the levy. Do I hear you say that NHIS will prefer an increase in what we pay in our contributions?
Certainly. NHI will welcome a conversation around premiums and that we pay realistic premiums. 30 cedis for as the highest amount to be paying into the scheme for a whole year is woefully inadequate. And there's good reasons why Kolebu wants to put up its rates. There's medical inflation. There's so many factors that goes into funding healthcare. And if your pricing has remained the same for almost 20 years now, that itself is unrealistic. So we must begin this conversation and must not stop.
And then secondly, you also said, once you collect the monies that we pay, it must be released to you. You also make that point. They should give you what is yours.
What is due?
Yeah.
What is due quickly, timely, and then if possible, all of it.
Okay, and that is important because we've seen that sometimes the releases, although the taxes have been collected, we paid, it doesn't hit your account, and that then cripples your ability to provide the services that we know you provide.
Yes, by design currently, this is what happens. It goes through, of course, the funds are collected by GRE, it goes through to Ministry of Finance, and so on and so forth. But yes, ideally, if there's a mechanism, to see this money come straight into the NHI fund, I'm sure that perhaps the conversation will be a bit different today.
Kwame Sapon-Asiru, this is one of the issues that you've talked about as part of the series, and you focus on the capping.
Evans, I'm just laughing. I'm sitting here and I'm laughing. It's ludicrous because look, in 2017, when this government came in, on the wings of a lot of us thinking that the previous government had been symbolic, and I make no apologies for my views then. The first thing they did was to pass a law to say statutory payments could be capped, and they could then decide what they were going to use it for. What they didn't realize, and that is why I always go by data, they didn't look at our 10-year disease trends to realize that our disease burden as a country was doubling. And we were moving from a situation where predominantly infectious diseases were the mainstay of our disease burden to a stage where chronic diseases are the mainstay of our disease burden. So, for example, currently, if you look at 2022 data, malaria is still the leading cause of mortality, but its contribution to our mortality has dropped by 46.6%, whereas strokes have gone up by almost 10%. So if you go capping the funds, when the diseases that are causing people to die are more expensive to manage, you cannot convince me that the NHIS, and that's why you've seen on my social media handles, I've asked the question, those people telling me and Ghanaians that the NHIS should take on and fund dialysis, where are they going to get the money from? The truth of the matter, and that was why some of us raised hell when this whole capping law was going in. The truth of the matter of a health insurance scheme is that you expect them to have an excess of inflows so they can invest it. So when they are recalled to pay for some of these more expensive procedures like chronic diseases, dialysis, prostate cancer, breast cancer, they can get money out of the investments they have made with the premiums they have received to pay for them. But this government, in its wisdom, telling us we have the men, took the money and said they can prioritize where the money should go. So I'm now listening to someone from the NHIS telling me that we are not liquid. And I'm saying, now who costs up? How can you be liquid when you never invested the monies that were coming to you for 6.5 years? You can't be. And that's why though we are having a serious conversation, I am laughing because I'm like, we shot ourselves in the foot and now we are bleeding and we are saying, how come the gun hurt? The gun was going to hurt. It was a bullet, for God's sake. It wasn't a sponge. It was a bullet. We shot ourselves. We expected to bleed. And this is why I'm saying this conversation should have happened yesterday. But it's happening now. So let's think of making sure that a lot of things like this whole capping and other things are repealed as a matter of urgency. Because I cannot sit here and say it's just straightforward. Then it's IS should take over funding of dialysis. They cannot afford it.
Okay, stay with me.
And they cannot afford it because of our laws.
Thankfully, the man who advises the president is here with me. When are you removing the capping?
Yeah, thank you very much. I think Dr. Siedu also knows that it's not every disease which every insurance covers. Insurance, I haven't seen any insurance which covers everything. Yes, there's the levy, and that's what Oswald was talking about. We will continuously be dialoguing to see where, for example, we'll get more resources for, first and foremost, the most important thing to me is not even anything, but first, a wellness clinic. That's one, for health prevention. And two, now we've been adding a lot of other things onto the NHI benefit package. Seriously, I believe that after adding sickle cell and then also accepting for cancer patients and prostate cancer, one of the things that we have to add is, for example, children of renal failure. And thirdly, I also know that acute renal failure of dialysis is covered. It's a chronic which is not covered. Most countries have other ways of paying for, either from insurance or from some top-ups or from something else. Yes, there's capping. If you are in a country where taxes are not what you are supposed to get, about 16%, now that you are moving it up, that's what governments will make sure that things work. But the dialogue continues. I've been on National Health Insurance Board before. We've been talking about how much can we health insurance take and become viable and sustainable. And as you rightly say, yes, insurance is you collect the money, you invest, and all sorts of things. When health insurance started 20 years ago, I remember very well in 2009, there was about over $300 million as in investment for health insurance, because there were only few people on health insurance. Now the number of people on health insurance is increasing. And I quite agree with him that yes, everything that you buy, including the water which is by me here, you pay a levy. If all the levy is not capped and is sent to health insurance directly, I'm sure we'll not be sitting here doing this conversation.
So remove the capping. When will that happen?
So we have to, as Oswald said, we have to do the actuarial studies to find out that if you are adding this, this is what you get. And then we move forward in that direction. When we do that, we may not even need increase in premium.
But you haven't addressed the capping.
Because in Ghana, I'm coming to the capping issue. In Ghana, we have a very unique health insurance where it's funded through levy. So capping, there's a dialogue which is going on between National Health Insurance, Ministry of Health, and the Ministry of Finance. If you are going to Ministry of Finance, from my experience, we have to go there with facts and figures, and this, which National Health Insurance is doing now. So now that we realize that National Health Insurance is having problems, and then maybe they're having liquidity problems, there's a capping. How much can you maybe take from health insurance to do other things? It's not only the benefits which the health insurance pays directly. There are other things. For example, health promotion, health education, vaccines for children, for vaccination, are all paid from the health insurance bills. And then initially also some for infrastructure development. So it's something which is being talked about, but that I'm sitting down laughing and all this, I don't think is the thing that they have.
Okay, so you're saying the government is considering the
Yes,
removal of
there's
the
a
capital?
dialogue ongoing, as Oswald said, and the National Health Insurance Board will bring that document. It goes to the Ministry of Finance, Ministry of Health, Ministry of Finance, sit down round table and discuss it.
Okay.
And come out of a solution.
Dr. Nsiansari, thank you
this,
very much.
This is a catalyst from what is happening now, that they are, especially the children and the other people who are on dialysis. What can we do to make sure that at least chronic dialysis, if for nothing at all, for children, is taken care of? And then you look at other things like the sin taxes and all these things. How can we collect sin taxes, things which cause hypertension, things which pollute our this? Let's tax them and put all of them in National Health Insurance Fund. And then the levy that you collect, how much does it come in? How much can we use so that we can cover all this, plus other diseases which are on, especially mental health?
Yeah. Well, Kwame,
Yes.
that's your answer.
Yes. You see, myself and Dr. Sias, I always have fun to say it. I love it when we're having it. But let me put it this way. He made a categorical statement that there's not any health insurance scheme that covers all ailments. That's incorrect. The UK covers it. He should tell me which disease is not covered by the NHS in the UK. Denmark covers it. He should tell me what disease is not covered by Denmark. Clearly, it covers it in Israel. He should tell me which disease is not covered. Norway does that, and so does Sweden. I don't want to go into other countries, and that is why I am a researcher. I do these things because I want to understand our problems and try and prefer solutions. So first and foremost, all I'm doing is I'm debunking what he's saying. The point is that health insurance by definition, should come to your aid in your point of most need. The question we should ask is, are insurance doing that basic requirement of a health insurance scheme? The answer is no. So the banter, I am laughing because we have waited since 2017 when some of us raised hell and got insulted. I was with you, Evans, on PM Express in 2017 when that was passed, where I got crazily berated by foot soldiers of this political party in power for something that we are now discussing that has gone north. And I don't like saying, I told you so, so I laugh. But we have heard the people who manage our insurance tell us that they need more liquidity. Could we have done differently in 2017? We could.
Except that he said tonight that the conversation has begun to address this.
I have an answer, but the answer should have been 6.5, 7 years later. And I asked myself the basic question, why should I be accepting of such an answer in 2023 when in 2017 we could have had the conversation? And for me, that is the frustration.
Okay. And listen, I want to bring in a few more voices into the conversation. I'll go to Kojo very soon because they are dying to get a bite at where we are with the solutions. The patients are there. They'll join us pretty shortly. I want to quickly bring Nasiba. You had the clip there from that protest that went on 2 weeks ago that went viral. And Nasiba complained about the death of somebody that she knew was very personal to her. And Nasiba, you've been listening to the conversation. Have you heard anything tonight that assures you that what you complained about will be fixed?
I've been listening to all the conversations that have gone on since the show started. And to be direct with your question, no. I didn't hear anything that sets my heart at peace that somebody is not going to die tomorrow because the person couldn't afford dialysis. And I didn't hear anything that is going to say that another Priscilla wouldn't go tomorrow. So I would only feel assured when I see words, I see action followed by the words. Now it's just talk. And I side with some of the comments that went on that this issue is beyond just having to work on your lifestyle. It moves beyond that now to a national issue that the government must intervene. And I understand that the taxes that we pay on health is so small, but we pay other taxes that are seemingly irrelevant. If all of those taxes were channeled into health, maybe we'll not even be having the conversation on kidney at this point. Maybe we should have been talking about something else, because over the years, things have evolved. Even in health, the things that are of priority are involved. Like somebody mentioned that malaria is not even something that we look at now. Now today we are looking at kidney and dialysis. We may not have even looked at that 20 years ago, 15 years ago. It was not even a conversation. But now it's a conversation, because it's happening and people are dying. And the only thing that stands between you and death is dialysis. And you cannot even access it. And we heard the Kolebu CEO, why they cannot even open it to OPD cases. And that's what stands in between you and death. So you are just dying, not because your body is failing you, but because your country is failing you. And that shouldn't even be. And so I've heard everything, but I still feel very...
Nasiba, thankfully, you have here with us Dr. Nsiah-Asare, who is a presidential advisor. If you have any questions for him, I'm pretty sure he can address the concern. Maybe we haven't asked that question that it will generate the answer that will put your mind at ease. So please feel free. You have one question for him?
You did ask him a direct question, though, about if Kolebu was going to get the help that
they need.
His answer wasn't direct enough. He said, he was the Kolebu CEO was in the conversation, and the government will do what they can in their capacity. It wasn't direct enough for me, and it didn't in any way even reassure me that Kolebu would get the help, because this sounds like an emergency situation for me. But we are still having conversations on how to. But this is health.
I wonder, though.
I'm listening.
Yeah, I know, but directly, you want to interact with him, ask me any question you want before you take leave?
So I would ask him again what you asked him.
Oh, you want to repeat that question? Okay.
Yes,
Okay.
I would ask him again.
That must be very important. Okay.
If Kolebu is going to get the help in terms of money, because that's what they've asked. They asked very directly that they need money and they need a sustainable system to be able to even fend for, because one of the things that the Kolebu CEO mentioned was that even looking at long term, even if the debt is solved, there's an issue of the consumables they have now.
Yeah.
They would have to increase the pricing. So what are the mechanisms in place that the government is looking at to sort of solve that situation very directly? And when? How soon is this? Is there a timeline to it?
Okay. Nasiba, thank you very much. Dr. Nsiah-Asare?
Thank you very much. Yes, we are very much concerned about the people of this country. And I think there are dialysis centers, not only in Kolebu alone. Komfo-Anokye is a government institution. They also have dialysis center. We are trying to get to know what Komfo-Anokye is doing, maybe which Kolebu is not doing. That's why Kolebu is coming on the limelight and people are talking about it. But as I said, yes, yesterday, the Kolebu chief executive and the board chairman were at the presidency. They've given them some work to do to bring what they are supposed to maybe get to make them move at this moment so that they can open up fully. The Kolebu chief executive said that the place is not closed to everybody, isn't it? Yeah, it's still open. So that is what Kolebu is working on it, and they will work on it quickly and it will be sorted out. But going forward, we have to get...
But she asked when. If you don't know, you can say now you don't know,
Kolebu,
but she wants to know when.
Yeah, so he can tell you when he's going to open up.
Oh, no.
It's not me.
and you see, he said the ball is in your court.
Yeah, so
he's saying the indication.
So we are waiting for what they are supposed to bring and then to be worked on. as quickly as possible.
And those of you who are listening to us on radio, you see a very, very interesting body language that went on. But that's why this conversation is important. That's why this is important. And at least you are making some progress on this. And Dr. Ampoma, I noticed your gesture to him and say, yeah, but this is in your court. Provide the money. Just to be clear on this.
The money is supposed to be provided by what? Ministry of Finance, isn't it?
Yes. Okay.
So Dr. Ampoma has to put everything that he's doing, that he's being asked to do, as quickly as possible in place. If I were him, I would use 24 hours to put everything in place and present it. Yeah, so they'll present it.
We've already presented.
And
no, you're free to talk because this is direct.
I've told him what to do.
Yeah.
And then quickly, I'm sure I know what normally such things are very dear to the heart of the authorities, and it will be done.
Dr. Ampoma, it's in your court.
As I said, yes, we were engaged with the Minister of Finance, and we were asked to present some numbers, which we have done. And so,
you've already presented those.
Yes, we have some numbers which we have done. And yesterday we were at the presidency as well, and the issue was interrogated, and so they're going to reconvene and call us back to. With some definite proposal. So we are hopeful that a solution will be found as quickly as possible. But having said that, I think that we shouldn't also forget that all of us are stakeholders in this together. So one of the things that sometimes saddens me about this country is that when there's an issue, because of the way we attack it along partisan lines, then the meaning is lost. And at the end of the day, see, we have a number of Ghanaians who are the center of this, and that should be our focus. And so, because sometimes when we go along the political line and we over-exaggerate and want to point fingers and point blame, then of course the other side becomes defensive, and then the whole meaning is lost. So I think that let us be measured in how.
And we've been very careful to focus on the issues tonight. You say you put the numbers together. Overall, how much? You mentioned 4 million before. That's the gap you have now. But is it more than that?
No, so it's 4 million. We have a 4 million deficit.
Okay.
And then if you are to run at full capacity, we will need about 961,000 cedis subsidy every month to be able to maintain the current prices because of the numbers that we are doing. We are doing about $2,000.
961,000 cedis every month to subsidize.
Yes, if we are to maintain the current
price. And you're hoping that government will provide that money.
Well, either government provides that, or we are allowed to some reasonable increase. So that's the kind of discussion we have. And then, of course, we are also looking for other Ghanaians, because First Sky has done tremendously well, subsidizing or in fact providing free dialysis by paying for 250 patients to have 2 sessions of dialysis every week. And throughout the year, free of charge.
So corporate Ghana should also join this particular.
There are individuals who have got high net worth individuals who can
also contribute.
And then, like I said, we had to talk about.
This really is a call to action. It's a call to action. We focus a lot on the government.
So I think we need a whole village approach.
Yeah, absolutely.
And then the other thing that also shouldn't be lost is that today is Kolebu, but we are not also just looking at Kolebu. We're also looking at across the nation. So that's why we're also investing in training and making sure that we develop the human resource, both doctors, nurses, biomedical engineers, who would then be at because at least every region in this country should have a place where people can go to for this kind of treatment. So we shouldn't also forget about the spread of the services across the entire country. Having said that,
very briefly, so yes, I can get the other.
Having said that, let's also not forget the impact of culture. Peter Drucker said that culture eats strategy for breakfast, meaning that no matter how much strategy you make, we shouldn't forget the impact of culture. And this culture is about us, the way we do things in this country, especially where people. We don't accept the fact that there are chronic diseases. So you find that if you look at the religious bodies, etc., there's this non-acceptance of course. So if somebody has hypertension, for instance, people look, if you're taking pills every day, it means it means that you don't have faith or that kind of thing. So people forget their pills, and then we have all this complication, and some of them end up with it. So the culture thing, the culture change is very important, and this is where the media and everybody should come together so that people see preventive health as a way of life, lifestyle for you.
Good. Kojo, this is where you really now get to give us a sense of where your panelists sit on the solutions, but also the solutions that have come from here.
Yeah, it's so interesting, Evans. I mean, I heard Dr. Nsina Sare talk about this interesting question of whether we should ask Komfo Anokye Teaching Hospital what they are doing different. For which reason Kolebu is getting the spotlight and they are not. I can tell you that in our conversations with the nephrologist in Kumasi, we have learned that actually at Komfo Anokye, the patients pay for their own consumables before they pay for the actual time on the dialysis machine. And that's been the case for a long time. At Kolebu, they are paying 380 cedis per session. We know that all the way down in Cape Coast, they are paying 350 cedis per session. So there is a certain lack of uniformity from government institution to government institution. We talked to 2 patients from 37 who said that the combined cost is about 1,000 cedis per session at 37. We don't know what's going on there, but nothing is uniform. Let's talk to our panelists. And here in the studio, we have, representing the Ghana Health Service, Dr. Fred Adumako Boateng. He's the Regional Director of Health at Bono East Region. We also have with us James McKeon Amwa. Now, he's a Senior Nursing Officer at the Renal Dialysis Unit of Kolebu. And we have 2 gentlemen who, the minute their money runs out, will die. I'm talking about Kojo Bafo Ahinkra and Thomas Vincent Khan, both of them renal patients. Sorry for putting it so starkly, but that's the reality you live with. Yeah. So you heard what the panelists have been saying to us. National Health Insurance says they lack liquidity. The president's advisor says, well, it will be considered. Putting it on the NHIS will be considered. Providing money for the OPD to take in renal patients will be considered. How do you respond?
See, they are the policy makers, and this is what they are telling us. But I wanted to ask Dr. Hassan Ansari that since they say the government wants to do something about it, that they are looking at it, they are waiting for Kolebu to bring the whatever statistics to them. They should open to the OPD. People are dying. That is where my argument is based on. So if it's going to take them maybe a week, a month, anybody can die at any time. Since they are now looking at George or looking at it now, the place should be open to the OPD patients and let us come. Even if something small, they will charge us. Who can put it down whilst the president is looking at it now? People are dying, my brother. People are dying. As I'm sitting here, I'm supposed to enjoy this air condition, but rather I feel very cold. I'm feeling cold. I wish we would close and I'll go home. So please, Presidential Advisor on Health, tell the president for us, they should tell the Kolebu CEO, whilst they are looking at it, bringing the figures, whatever it will take, from now to the time, they should open to the OPD people. If they don't take care, all of us will come back to be impatient because we are getting sick. And before they realize, all of us will be on admission and we will all be impatient. But probably if they could have opened it to us and we are managing it small, we will not be coming back to be award. So we are begging them. They should look at that place. The OPD should be, the cabin should be open to the OPD patient for us. We beg them.
Thomas.
Yeah, I think that Kojo, in all of these things, it looks like we've narrowed it just to Kolebu. But I think it's a national crisis. And it should not be just be Kolebu. Until recently, people from the Western and Central region were just sharing Cape Coast Teaching Hospital for dialysis.
How many machines there?
It was 15. As I speak to you, Kojo, we only have about 5 functional machines. Just about 5 functional. And recently, the Cape Coast Teaching Hospital had their 25th anniversary. And it was in their speeches that they were also looking forward to find means to get some of the machines. And again, we as patients over there have been complaining about the price. It was 280, and then recently they shot it up to 350. And, you know, that's already is a burden. And it is time for us to hear something positive from the government. And I was thinking that Dr. Nsiah Asare, with all the dialogue thing he's talking about, we want some kind of assurance that, the prices are going to go down. Government is going to give a subsidy. These are some of the assurances that the patients want to hear. But if it's just going to be dialogue, that does not even give us some kind of assurance, and it's kind of disappointing. And sometimes we feel very, we feel very down when we hear some of these things. So, Dr. Nsiah Asare and your people, I don't know if we have to come and see the president ourselves so that we can tell him how we feel, because it's not easy. Kojo, this conversation we are having is really broad. To tell you the truth, even if you want to have a fistula, the fistula surgery alone, people from Western and Central or wherever, from the other places, they have to travel all the way to Accra just to have the fistula surgery to enable you to do the dialysis.
To clarify, the fistula surgery is a surgery to implant sort of a means of getting the blood out of you into the dialysis machine and back into you.
You have to get the fistula. That is the kind of like the gateway for the dialysis process. If you don't have the fistula or you don't have the catheter, you can't have the dialysis.
And you all have to come
to Accra for that. Meanwhile, the other hospitals have surgeons there, but that is a specialty. It's not every surgeon who can do that. So if you have to have dialysis or you have to get the fistula, you have to travel all the way to Accra. Look at the risk involved. Look at the money you have to spend. So all of these things is a burden to the patient. So I don't know what the policymakers and those who matter, I don't know what they are thinking about, because it's a whole lot. And this thing that we have narrowed it to the cost alone, Kojo, in fact, it's something that is really affecting people psychologically and emotionally. And I've said it over and over again. This is a disease that when you have it, it psychologically breaks you down, and it's even killing people faster than the disease itself. So it's about time Dr. Nsiah Asare and his team members do something about it. And like I said, I don't know if we have to come and see the president or whichever panel they have, so that we can show them how we feel, and then even show them the scars on our body for them to know the reality of what the problem is. Now we don't need the rhetorics.
Yeah,
we need action.
Without the last two guests, James and Dr. Fred, I want to do some fact checking, if you don't mind. James, I heard your CEO of Kolebu. The numbers seem strange. You told us you have 9 dialysis machines. Then he said no, there are 12. Then he said there were 15. Now there are 13. I'm confused. How many dialysis machines are operating at Kolebu as we speak?
Because I don't think that the point just putting me in with difficult for me to answer.
Oh, but you work
because,
in the
you see,
in the renal.
And I was
unit.
going to say that right now I'm wearing 2 caps as a nurse in Kolebu Teaching Hospital and from Ghana Public Health Association. So let me draw my cap from Kolebu now and speak, listen to all that we've said as a public health practitioner and a scholar in global health. We need to look at the issue of dialysis care, one from the non-communicable disease perspective. How do we address the issue of non-communicable disease? Because it's on the rise. Number 2, in dialysis, and from my experience as a nurse, we're looking at access and quality. Mr. Ankara made the case when he says that when they visit the other private dialysis centers, they don't get the same quality as they get from Kolebu. There are patients I would not recommend to certain dialysis centers in Accra, but they are working. They are charging 400, 500. Patients end up coming back to Kolebu emergency with some problems. HIFRA must start looking at all of them, start vetting those dialysis centers in Accra. The other issue is, and I think that health insurance may not be able to accommodate it, because even with the acute kidney injury, that has a flat rate of 850 cedis for the dialysis sessions. Those days, could do about 3 or 4 dialysis sessions before.
Wait, tell me, there's a flat rate
of 850 Ghana cedis.
You pay that, and that covers all of your
That's what the
dialysis
insurance
sessions.
pays for the acute. The acute is the initial one that there's possibility of you recovering from the kidney disease. So if the NHI pays 850 cedis, it could do like 3 or 4 dialysis sessions for you. And by the time those sessions are done, your kidneys recover, you are good to go. But if you have to do more or additional one, then you must pay the difference.
So they don't actually cover the whole treatment for acute renal failure.
In that case, it becomes a chronic kidney disease management.
Right. So it's just 850 cedis that we get from the NHIS.
Yes, and those are what $265 then. But it was quoted in cedis. So if they should bring down to currently what we have in with a dollar around 11 or 12, then we should be looking at more than almost 3,000 cedis, which can also take care of an acute kidney injury patient who may need 5 or 4 dialysis sessions. But at the moment, as it stands now, you can do about just 1 dialysis session for the patient. So there are certain things that I think I need to share with you and all of us as things we can do to help. One, I think that there should be a fund for dialysis care. Health insurance may not be able to do that. And how do we get monies for this fund? Number one, I think that companies that do a lot of CSR, corporate responsibilities, that focus on musical shows, beauty pageants and others, should now redirect their focus to supporting things that are more sustainable. If a fund is created and these big companies decide to some of their monies to this fund should go directly to those institutions that are managing this care. So if Kolebu Teaching Hospital will get, say, 10% of that fund, the money comes straight to Kolebu, which can be used for its management. If you have to go to Cape Coast Hospital, if they need 5%, it should go directly to them for it to be done. Secondly, we talk about excise duty, which I mentioned about the sugar-sweetened beverages and tobacco, as another panel mentioned. We can use these same taxes, raise those monies, and use that money to support the care of these dialysis patients. And if you look at the fund, we could look at doing what we call research, because we need to do research in health. Secondly, capacity building for the workforce. Dr. Nsiasare mentioned, one of the panelists mentioned that we have 18 nephrologists in Ghana. All of these nephrologists are in Accra. Kumasi and Accra and Kumasi, sorry. Other regions may not have anything at all. The nurses that are working in dialysis centers, even in Kolebu, none of us have gone through any specialist training. We are all general nurses who have learned on their job. But we need to have nurses go through training to become nurse specialists to manage these patients, something that really has to be done. A lot of investment should go in education. Finally, government should invest in dialysis care. Because you do know that, and I'm sharing this with you and to all of us, that there are many regions in this country that has no dialysis machine.
Yeah, 7 of them.
Even in Kolebu, you realize that some of the machines, they doesn't belong to Kolebu. Because we must source machines from providers and then later pay for it. I learned one dialysis machine costs around 11,000 euros. Look at the VAs that we have in this country. Look at the money people are splashing. Can one person decide to buy 5 or 4 dialysis machines for Kolebu to buy the consumables from another place at a cheaper price to help us manage our patient? These are things that we need to look at. If not, we'll not make progress.
Yeah. Dr. Daniel Macaulay donated 5 dialysis machines to 37 military hospitals. Many other people have donated. Many companies have donated dialysis machines, but clearly,
and then the maintenance. We may donate, but maintenance.
Indeed. All right. We'll continue our fact checking. And Dr. Fred Adumako Boateng of the Ghana Health Service, both yourself and Dr. Nsiasare have said that these wellness centers are yielding results. That's your contention, right? That they are yielding positive results. Yeah. Well, I've been looking at the 2022 Holistic Assessment of the Health Sector presentation done by Emma Ofori-Agyeman, who is the Director of Policy Planning, Monitoring and Evaluation at the Ministry of Health. She did this on the 5th of June this month, okay? Now, according to her, and these numbers are quite clear, they don't lie. From 2017 until 2022, the number of outpatient visits per capita by region has literally not changed, not really gone up or down by much. So the same numbers are going to hospital every day. How can you say your wellness program is working then?
So thank you. I'll address this and also add some. Internationally, the standard for OPD per capita is 1.2. It means that at least every year, each and every one of us should attend the hospital once. So when we say the OPD per capita, it's 1.2. Now, you shouldn't get more to show that people are coming or less. The moment you get less than 1, then it means there is a challenge. Because what the OPD per capita is used for is a standard internationally, 1 or 1.2. So if you are getting 1.2, it means that you have met the criteria.
But if people are still attending hospital only once a year, then that means your wellness center hasn't changed people's health-seeking habits.
It's based on the interpretation. They are what we call standards and indicators, and they are set for comparison. The fact that maybe you have 1.2, 1.3, and it's not 1.5 doesn't mean people are coming. There will be regional variation. So in terms of OPD per capita, I think internationally, Ghana Health Service, we are meeting the criteria. But I will also want to come into this, and I'll come to the wellness clinic. You know, we are saying kidney disease, and this particular discussion has been on end-stage renal failure. I think it was bigger. The discussion should be bigger than that. But then I will also, if you look at the USA, 15% of the population that go on to the end-stage renal failure are the aged. Right. And because they are aging population. But if you come to Ghana, the context is not the same. We have to look at this particular one. Because look, the reason why we are here is inability to fund the people who really need it. The problem we are discussing is that, look, if we really manage the spectrum very well, and I'll come to that, the median age for people who have end-stage kidney failure from the discussion in Kolebe is 29. My brother, 29 years. So it means that if they are going to put somebody on, and here the treatment of choice is what? Kidney transplant. How long can you be on this for a long? Quality of life. So if somebody is 29 years, and we don't pick this person, and it will come back to that issue. The studies that have been done by Autry and et al., the median age was actually 47 plus 16, which means the range is from 31 to 63. And look at the population in Ghana. Majority of them are below 40. The question that we should be talking about, this chronic renal failure that we are talking about, what is contributing to that?
That's a poignant question. I wish we could continue, but I think our time is against us. We have to come back to you, Evans, and the questions just keep coming. I wonder how your panelists take them.
Kojo, thank you very much. We're just wrapping up now, and my panelists with me in the studio. We're taking quick action points on the back of this discussion tonight. And I want to start with you, Perpetual, with the Ghana Registered Nurses and Midwives Association. What are your action points on the back of this?
So, first of all, I want to state clearly that health is a right. It's the right of every citizen, and it is the responsibility of government at any point in time to take care of the health of its people. So it's important that if we are looking at 2030 in achieving universal health coverage, and the fact that accessing health should not bring financial burden on populations of nations, then it's important that the government takes this issue up seriously. Let's remove the cap of the NHIS. Let us ensure that the premium and all other levies are channeled to the NHIA to actually implement the National Health Insurance Scheme in such a way that it's able to cover kidney diseases, the management, the treatment, the transplant, and everything that there is to it, so that we can even add on other conditions. Because we have even heard from the NHIA individual here on the panel that once they are liquid enough, they should be able to cater for all these things. So that is an urgent need from all of us as Ghanaians, and it's important that the government takes this up. And I'll plead with
Dr. Nsiah,
Dr. Nsiah to go back and let His Excellency know that this is what Ghanaians are calling for, and let us do it.
I have 3 minutes. I wanted to share along.
Okay, so prevention is also very key.
Okay.
It's very key. Education, education, education. Let us move on. We've talked about specialist training for doctors, for nurses, and for all those that are involved in the care of our citizens. It's very important.
Dr.
Let me end it there.
Your key action points?
Yeah, so I think we've talked of prevention. I think there are some things that are worth repeating. So prevention, but then there are some people, subsection of the population, like children, who are born with certain conditions that made them predisposed to renal failure. So for those ones that fall out of in that net, we should have a scheme that takes care of their needs. And that's why it calls for all of us to engage and find ways of sustainably funding kidney services, including transplantation, which is something that the Kolebu Teaching Hospital is focusing on, and which we hope that with the completion of our new Urology and Nephrology Center of Excellence, this will be something that will be regular practice. But as we said, we all need to work together and then also make sure that the services are supported and decentralized across the country for universal health coverage.
Okay. And also joining us quickly for the quick action point, Professor Antwi. He is obviously the president of the Ghana Kidney Association. Prof, what are your key action points?
Yeah, so thank you very much. So I think enough has been discussed on this dialogue, but I like one statement that somebody made, that beyond the prevention, Ghana Kidney Association, we champion prevention a lot because we know that if we can prevent people from getting to end-stage kidney disease, it is so cost effective, we will save a lot of lives. So prevention is good, but currently there are people who unfortunately, either through their fault or no fault of theirs, they've gotten end-stage kidney disease, and now they can't foot the bill. And the main reason is that because of the exchange rate of the dollar. Look, let me tell you something. I'm just ending quickly. In 2015, I read a publication. The cost of dialysis at that time, I think the CEO of Kolebu said it, was 200 cedis. And that one, it translated into $65 because the exchange rate was $1 to 3.2 cedis. Now, today, even at the proposed increased realistic price of 765, if you divide by the current exchange rate, 11.45, it is still 67 cedis. Why are people not able to afford it? In 2015, they were able to afford it. It was $65. But now they can't afford it. That's because of the exchange. And so it is time government should do something about this.
Okay.
It is all about the life of people.
Okay.
If there's no medical cure for a disease, unfortunately, if you get it, you die. But where there's a medical management, not cure per se, because end stage is not a cure.
So your key action point there is?
My action point there is that it is time for government to call for immediate dialogue. GKA, we have already approached government. And I think the dialogue must happen now, and action must be taken immediately.
Okay. To make it free. Okay.
Affordable, yes.
Affordable, not free. Great. Kwame Sapansiru, quick 30 seconds, quick action point.
My biggest action point is the conversations should continue, and I would say this. My brother Fred says globally, outpatient per capita is 1.2, so we are meeting it. I am clear in my mind. I said proactive health systems, it's 4. He cannot dispute that.
Okay.
And if we are going to compare ourselves with Mali, where outpatient per capita is 0.19, to Sweden, which is about 12, and strike an average to say 1.2, then we definitely don't want to develop.
Okay, so
that is how
quick action point, continue the conversation. Final word to you.
Yes,
Dr. Nsiah, what's the quick action point
thank you very much.
And the government?
Thank you very much for this conversation. Listen to everybody. But I think what some people should understand is that you don't take a decision just all of a sudden. You have to get all the facts, and that's where the dialogue comes in. And as Professor Antwi said, the dialogue began some time ago. we strengthen it and end up to C. The most important thing is that, yes, is the affordability of the care of the chronic renal failure. And in order not to put so much burden on everybody, patient and government and everybody, as everybody has said, prevention, prevention, prevention. 2, we have to also take care of everything. Those, for example, children and other people who, for no fault of theirs, also develop chronic renal failure, we have to also, as quickly as possible, see how we can take care of them, like we are taking care of other children with other diseases like sickle cell and the rest. So this is something that government is very active, and they will continue to dialogue with everybody. And then, as I said, training is very important. It's not only Kolebu should have all the people who can access. For example, somebody was saying, if you want to do the fistula, you have to come all the way to Kolebu. That's the reason why the CEO of Kolebu said that recently we've taken a decision at the Ghana College and I think Ghana Nurses College to also College of Nursing and Midwifery, that we should decentralize our postgraduate or residency training.
So that's something that government
That's
is
something
also
that government, yes.
And then you've also talked about removing the capping.
Yes, removing the capping.
Okay.
So we shall continue dialoguing to see how we can mitigate that, to get enough money in health insurance to cover what we want to take care of. And secondly, we also
very finally, because of time, you just have now just 5 seconds to hit that nail on the head.
So I will thank you once again, and then we will take this thing up and then work closely together with Kolebu so that they open the center as quickly as possible. That's how we want to make it.
Unfortunately, Dr. Fama, that time is up. And Kojo, that will be music to the ears of your panelists you've been with, because the fundamental question they asked was, when is Kolebu opening the OPD? And we just had the assurance there that it's going to be done as soon as possible.
No doubt. Music to their ears, that's exactly what it is. Because let's not forget, we're having these conversations because, well, people are dying. 15-year-old Priscilla died while we were talking. So it's about time we started taking action so that we can stem the flow of death. For those listening on radio, if we can quickly apologize, we should have brought you Personality Profile with Dr. Ishmael Yamson. That will be coming to you at a later date. We apologize, but of course, you can see it's for a very important national cause. Evans.
Indeed it is. And whilst we've been talking, following this thought leadership discussion, many of you, some corporate entities as well, calling, they want to help. If you're attached and willing to help the patients on dialysis, the facilities doing it as well, the multimedia group will provide an avenue for you to do so. And so reach out as we do this together. We do this together. Enjoy the rest of your evening. And this has been a special Joy News thought leadership event put together by the Health Desk, led by Fred Smith, who obviously had worked tirelessly to make sure this indeed comes to you. And we're grateful to you also for staying to listen. We're going to leave you with how to ensure that your kidney remains healthy. A few points there that you need to note. And as you've heard already tonight, prevention is absolutely critical. My name is Evan Spencer. Enjoy the rest of your evening.